Hello, my name is Dr. Matthew Schwartz, and I am an emergency physician practicing at Northwell Southside Hospital in Bayshore, New York. I am also a member of the Southside Hospital Sepsis Task Force. I'm going to be presenting some of our data today. Compliance with fluid, bolus, and broad-spectrum antibiotics reduces sepsis mortality, but does not reduce 30-day hospital readmission. Well, special thanks to our department vice chairman and one of the leaders of the task force, Dr. Garra, as well as our sepsis coordinator, Darlene Parmentier. Sepsis remains a leading cause of morbidity and mortality within the American healthcare system, affecting nearly 1.7 million Americans yearly and directly contributing to over 380,000 deaths. In addition to this great toll of human life, it's also a very expensive medical condition, accounting for over $41 billion in healthcare expenditures yearly in America. And finally, patients with sepsis have a hospital length of stay that's 75% longer than the average length of stay. Given the toll both in dollars as well as in human life of sepsis, there's been a push in recent years for improving sepsis care, most notably by the interdisciplinary International Surviving Sepsis Campaign, which has had 4 separate iterations, first starting in 2004, most recently in 2016. The recommendations from this committee have led to the widespread adoption of sepsis bundles, which have multiple components as benchmarks and suggestions for management of sepsis, but 2 pivotal components are the 30 cc per kilogram IV fluid crystalloid bolus, as well as the rapid administration of broad-spectrum antibiotics. In prior literature, it has been shown that compliance with these recommendations decreases mortality in sepsis patients. However, the effect on hospital readmissions has not been well elucidated. And given the recent push for curtailing not only readmissions, but the healthcare costs that come with that, we thought it would be very interesting to see how this would affect, how these treatment protocols would affect sepsis readmissions. Northwell Health, our data collection occurred in the Northwell Health system, an integrated healthcare system of 23 hospitals centered in and around the New York metropolitan area. And there's the Sepsis Task Force, which will prospectively collect data from patients from 12 of the Northwell facilities. Now, these include tertiary and academic facilities, as well as small community hospitals. And so essentially who gets included in this performance improvement database is anybody who meets the well-accepted sepsis criteria, those presented either to the emergency department or who were admitted to the floor and then subsequently developed 2 STIRS criteria with a suspected bacterial infection. And with this would trigger a code sepsis, which would not only trigger a uniform treatment protocol, but flag the chart for inclusion in the database. And what we did is we looked at patients in this database from 2016 to 2018. And in doing so, we were able to track that we can track the disposition, mortality, length of stay, and readmissions to any hospital within the health system. So for our study in particular, we just wanted to isolate patients who met the criteria for severe sepsis, not just any septic patients. So this included patients with sepsis and signs of end organ damage, as identified as a lactate level greater than 2.0, a creatinine greater than 2.0, a platelet count less than 100,000, a bilirubin greater than 2.0, INR greater than 1.5, altered mental status, new respiratory failure or hypoxia is defined as a oxygen saturation on pulse ox less than 90%, or urine output less than 0.5 milliliters per kilogram per hour. Anybody who's excluded were if a patient or a healthcare proxy opted instead for hospital comfort care measures rather than full aggressive care, or if we had a clinical condition that precluded the 30 cc per kilogram bolus, which we identified as a acute pulmonary edema or new onset end-stage renal failure without having already established dialysis access. So we were able to retrospectively look back at the care that was rendered to these patients and could group them into being either compliant or non-compliant on our 2 interventions. Broad spectrum antibiotic administration within 180 minutes and appropriate fluid resuscitation, both in the volume of fluids, 30 cc's per kilogram of IV crystalloid, as well as administering this volume within 30 minutes. And we were able to look back at our outcomes if the patients were compliant both with each intervention independently, so just with did they get their compliant with their antibiotic administration, yes or no, compliant with their fluid resuscitation, yes or no, as well as with both interventions combined. Our primary outcome was, were these patients readmitted to a hospital within our healthcare system within 30 days? And our secondary outcome was looking at the raw mortality of the patients. In total, we had 18,207 visits, a median age, a little elderly at 71.9, and a slight male predominance at 52.3% male. As far as readmissions, the overall readmission rate was 11.8% in these severe sepsis patients. And we found there to be no statistically significant difference in readmission rates between cases that were compliant in both antibiotic and fluid administration and non-compliant cases. As you can see from the numbers, the compliant cases trended towards decreased readmission, but this number was not statistically significant. However, if we then broke it down to just the individual interventions, it looks like that the readmission rate did improve a statistically significant amount if we just looked at the fluid administration rate, whereas it did not. There was no statistically significant difference when we just looked at whether they were compliant in antibiotic administration or not. And this is or just our data numbers in graph form, as you can see. Moving on to mortality, the overall mortality in this patient cohort was 16.7%, and as was kind of expected and shown in prior literature, there was a significant improvement with either intervention in mortality. And if we looked at both fluid and antibiotic compliant cases versus non-compliant cases, there's a 14.3% mortality versus 18.8, with a statistically significant p-value. And again, if you just did a subgroup analysis, whether the patients who were fluid compliant, yes or no, or antibiotic compliant, yes or no, they both were shown to have statistically significant improvements in mortality. And again, looking here, this is just throughout the 2-year study period, our data in graph form, with the green line being the compliant cases. So as we can see, as was kind of expected, the compliance with sepsis bundle requirements did improve mortality. However, they did not significantly alter the rate of hospital 30-day readmissions. But perhaps the IV fluid administration is really a vital component in sepsis care and does seem to decrease hospital 30-day readmissions in severe sepsis patients. Now, what limitations are there in our study? Well, first of all, we did not differentiate between severe sepsis and septic shock. Perhaps if we did, we might have seen a more profound difference and improvement in our outcomes if we were looking at the more severely sick patients. We did not account for any comorbidities. Obviously, maybe if we were to, again, do a subgroup analysis and say if somebody was immunocompromised or not, or anti-adrenal or not, we might have seen a difference. We didn't examine these vasopressors, whether it happened at all, early or late in the course of this patient's care. Another outcome was, another important limitation was our outcome we measured was all-cause readmission. It was not specific for fever or infection. And so obviously somebody came back 2 weeks later after a sepsis admission following a traumatic event, that might skew the data somewhat. And if you look, there was a wide month-to-month variation in the total number of readmissions, saying that perhaps there are other mitigating factors that might have influenced these readmission rates. Our fluid administration goals were in 30 minutes, not 180 minutes, which is a little even more aggressive than some of the standard guidelines. Again, while our data was collected prospectively in this database, it was analyzed in a retrospective manner. We find there are other endpoints that might be interesting for further study, that to see if these interventions improve, that would be of clinical significance. Did they change length of stay? Did they change the morbidity level and functional level of patients upon discharge? These are all things that with our database we hope to look forward to and further investigate in the future. These are my references, and thank you all for your time. Be safe, everybody.